So the idea for the Acute Care Fellow job was to try and enhance out-of-hours care, improve what we can offer. And if you look at the rota, sort of pre-2014, this was the medical SBR rota, and essentially you'd have blocks of nights, which are C on the rota, usually on AMU or on the wards. You'd have some weekend day shifts, and then during the week you'd have these random long day shifts scattered throughout out the weeks. And these were the days where you're either on AMU or you were on call on the wards. The problem again with that is the random days on the wards didn't really add much in terms of your training, and again they were difficult to manage because of the workload. If you were on the AMU days, again, that didn't really add anything to your training or continuity care. If you're only on AMU for a couple hours in the evening, seeing a few patients, you're not there the following day because you're back on your routine clinical work. You don't get continuity care, you don't see what's happened to that patient, you don't follow them up, you don't present them on the ward round. And I think that's bad for the patients in terms of it's a different doctor presenting their case compared to the one that saw them. It's bad for you in terms of your training. You're not learning what's going on, you're not seeing the consequences of your treatments. And that was the rota that we had. So to improve that, we developed the Acute Care Fellow. So there are 6 of us in total. We are all senior registrars, years 3, 4 upwards, so ST5, ST6. And between us we cover a range of specialties. So we've got registrars from gastro, endocrine, cardiology, respiratory, which actually is really helpful, particularly at weekends when there are a couple of us on. You've got a range of specialties covered. And the day team will say, we've seen this patient, they're stable, there's a gastro-specific problem with them, what do you think? And it's nothing acute, but it's the sort of thing you can give an opinion and it will still advance their care over the course of that weekend. The same with cardiology, if patients come in, they've got X, Y, Z, they're fine, they're stable, anything else you could do. And it's the sort of thing that, say, their regular team would do on a Monday, so that the registrar that's doing cardiology would say, well actually, if you do X, Y, Z now, do these bloods tomorrow, care's already been advanced when the team come back on a Monday morning, that's already in place, it's happening. So we've got a range of experience. We're available because we're all out of programme doing research. So that's either lab-based research, clinical research, leading to either an MD or a PhD. So we're out of clinical training for a 2 to 3 year period. And really what the role is out of hours team leadership. So you've already, I guess, heard about the doctor's work list and the changes in IT that they'll have allowed us to see the workflow through the wards. We start at 4 o'clock in the afternoon and work until midnight, Monday to Friday. There's also an additional shift, Friday, Saturday, Sunday, where we work from 4 in the afternoon to 4 in the morning, so a 12-hour shift. And really the role is to support the out of hours team. So there's an F1 that starts with us at 4 in the afternoon. And what I generally try and do is do a sweep of all the medical wards at that time, when the day teams are still present, really tying up loose ends, trying to look for the patients that are acutely unwell that the day teams are worried about, patients that you need to know about early. As a prompt to the teams, are your fluids done, are your warfarines done, are your bloods back? And often you get the teams, we haven't quite done that yet. Well, can you help me if you've got time? Can you make sure that the fluids, the warfarines, the bloods are done if they're available? Because that cuts down on work out of hours. And sometimes you pick up things where the team are handing over jobs that don't necessarily need to be done. So again, it's the routine checking of bloods. And sometimes, particularly with the junior staff, you say to them, well, why are you checking the bloods? Are you worried about the patient? Well, no, it's a routine check. They're not unwell. We always do bloods every day to check on the patient. And then you say to them, well, unless they're acutely unwell, or unless there's a clinical concern, there's a change in their MUs, could these bloods be done tomorrow? Think about what you're doing out of hours. Is it necessary? How is it going to advance patient care? Or are we just going to do it? And so that's an important part of the role. And then because we're at SPR level, it's timely review of patients who are unwell. We're starting afresh at 4 o'clock, we're ready to go. We haven't got other clinical commitments during that day delaying us at 4 o'clock. We can start tackling the out of hours jobs as they come in. With the work list, we know where the sick patients are, and it's a case of directing the right patient or the right doctor or team member to that patient. So whether you go and see them yourself early, whether you think that it's somebody that the SHO could actually go and see them, you can then review them. If it's Venflons, cannulas, have you got a medical assistant with you that you can go and sort it out for you, which frees up your clinical team. We also take a teaching role, and that's either ad hoc on the job, teaching the SHOs, the F1s, the medical assistants, and that's a two-way thing, reviewing the acute patients with them. And then also sort of formalised, standardised teaching. So we have once a week we have an open hours teaching session, usually a handover meeting for half an hour, going through an acute topic, either related to patient care, management, leadership, and all of the fellows present on that, and it's a teaching experience for you. But it's just, again, education. So it's an education opportunity that you don't normally get out of hours. Normally you're by yourself, middle of the night, and nothing really happens, whereas it's a supportive environment. You can offer education, you get education back, and it makes it worthwhile. We've also, with our nurse practitioners that work with us, some of them have been advancing and doing advanced nurse prescribing modules, so learning to prescribe drugs, examine patients, which again is an asset to our team clinically otherwise. It's an extra team member that you can use. And we've been involved in not only learning from them and some of the nursing side of things, but teaching them. So you can take the nurse practitioner around with you, which means that you can often get things done in twice the time because they know which wards stock which drugs or which form you need to fill in or who to speak to. And in return, we've gone through examination with them, clinical prescribing, so it's an ongoing learning thing. As I said, there are 6 of us, and we offer a service 7 days a week, 365 days a year. And the way that we've organised the rota is we do all our shifts in a 2-week block, and then you have 4 weeks where you don't have clinical work and that's your research time. And if you're doing your normal day-to-day job, you're in clinic in the afternoon, you're in endoscopy, so you don't necessarily start at 5 o'clock. If clinic runs late, you're there till it finishes. But the on-call work starts at 5. So the pressure on you can be absolutely huge. You're being pulled in alternate directions as one of you, and you're delayed. And that means that in that 3 or 4 hours that you are on call out of hours, you're not actually achieving anything. You're starting late, you've got a huge amount of pressure. The day team that you're working with, the SHO and the F1, are in the same position, so technically they're not starting at 5 either, they're tied up with their day work. And you find that actually what you're doing is you're trying to tidy up loose ends, but you're not really advancing patient care because you haven't got the time, you haven't got the capacity to do that. And you're just trying to patch things up, keep things going, and then the night shift arrive. And then it's the same thing we were talking about earlier. If things aren't done during the day for various reasons, it gets more difficult to do them out of hours if you haven't got the staff to do it, which then leads on to the night staff struggling as well. And you just get this knock-on where out of hours not a lot happens to advanced care, and you're trying to patch things up. In terms of benefits of the acute care role, I think it's all about making sure you've got the right person in the right place for the job. So it's there with continuity of work, it's advancing patient care, which otherwise doesn't normally happen out of hours. It's improving patient safety, because patients are being reviewed at senior level out of hours. If they're reviewed by the SHOs and the F1s, they know we're around, we're on the shop floor, on the wards, it's easy for them to say, okay, have a quick look at this. Because there are more of us, we can divide the work up. So particularly at the weekends when the workload's heavy, two of the registrars will be doing the acute stuff, seeing the ward transfers. The third person will mop up and do all the routine stuff that's still outstanding, which again then takes the pressure off. And then from a personal point of view, I think it's becoming increasingly difficult to take time out of clinical work to do research because of funding. And in doing that, you potentially lose your clinical skills. If you're in a clinical work for 2 or 3 years and you don't see any patients, things move and things change quickly, and it's very easy to de-skill. And even lose your confidence in managing things because things change. Whereas by doing this role, you maintain your leadership, you maintain your management, you maintain your clinical skills, and those skills are retained within the NHS. So traditionally people doing research would go off and they do locum shifts, on AMU or A&E, not necessarily in the hospital that they've trained, which is a shame, if that hospital's then losing that skill set, or you're paying agency fees to get a locum in who may have worked in another hospital but not your hospital. Whereas this way, you have senior registrars, they are retained within the hospital, they're working out of hours, maintaining their clinical skills, improving patient safety, and it provides a way of supporting clinical research, which again, longer term, will then is going to benefit your service, the NHS, you. And I think having worked in a system where the Acute Care Fellow didn't exist, and working here where it does exist, and having done that role, it's been generally well received, and it makes such a difference. Being on call otherwise is an absolute nightmare because you've got the whole hospital, all the medical beds, you've got the referral bleep, you've got the SHO to supervise and support and the F1, and it's just unmanageable. It doesn't feel safe. It feels like you're just literally patching it up, trying to avoid a disaster until the next shift come in, and they do the same until the day shift come in. Whereas now, out of hours, the hospital feels calmer, it feels more under control, morale is better, and it's not just a case of people there to do the job. There's a whole, it's part of the working day, it's supportive, there's learning opportunities, it's just a better, happier place to work. I mean, yes, it makes a difference. So having the nurse practitioner helps with the day-to-day running of the team. It's essentially an extra member of staff. They can help with the organising investigations, chasing up results. They're particularly good with social care. We have a lot of problems trying to get patients out of hospital because they're medically fit, but there's just nowhere for them to go. And we have problems with patients who are 70s, 80s, and because of the social care situation at the moment, it's difficult. And equally, the patients that are younger and have advanced needs socially, but because they're 50s, 60s, it's really difficult to place them. So the nurse practitioner, coming from the nursing background, knows who to speak to, knows which form to fill in, and tends to drive that forward. So that's a big benefit to us clinically. And then again, so having the medical assistants around on the wards, it's a great help because bloods are done, or the request to put it the following, the day before for the next day. So that's your routine stuff. But then, we're an acute specialty, we get pickups on the ward every day, transfers coming in from the acute unit. And if you want bloods done that day, in places where I've worked where you haven't had a medical assistant, that then means you lose a member of staff from the team. So your SHO or the F1 or me would stay back, do the Venflon, do the bloods, do the cultures, whatever. That takes them off the ward. And if they're the only one that knows the patient, because of the way that the teams used to work, that makes things difficult for continuity of the ward round. Whereas if there's a medical assistant that is going to come to your ward every day, your routine bloods are going to get done, but that they cover a set cohort of wards. So if you get additional stuff during the day, you can give them a bleep, give them a ring, forms on the ward, forms in the notes. They come down, they'll come and do the bloods, and within a couple of hours you've got your results back. You can make the decisions earlier. You can move care forward. Whereas in other places where I've worked, where we haven't had nurse practitioners, we haven't had medical assistants, it's down to the clinical team. And if you've got a list of 30 patients you're on take, you're with a consultant, you go around, you see all the patients, and then you've got to go back and do all this stuff, in addition to your routine day stuff. That's when you run into problems. Things don't get done in working hours, it goes on to out of hours, which we'll talk about, they're busy, and it's just a knock-on effect. So I think it just, the more people you have doing specific roles and dividing that workflow up, it just improves the whole flow, and you're sharing the workload, and patient care is better, staff morale is better, and you're not swamped, and it's manageable, it feels safe. And I think that's the big difference.